First of all, let me just let Dr. Rageshri introduce herself. She's on the medical board of the BAME charity NAS, which she has been since 2013. She's a trustee of the British HIV Association and chair of its External Relations Committee. But most importantly today, she has done a lot of work on the structural inequalities that exist in the health system. Could you tell us a little about that, please, Rageshri?
Thanks, Jo. And just to say, it's a real privilege and honour to be asked by UK CAB to do this Q&A today. So thank you very much. So yeah, as you said, I have been doing work around ethnic inequalities for a few years now, working in East London in sexual health and HIV, and especially with my work with NAS, I've been really conscious of some of the issues that BAME people living with HIV face. And this has really impacted on my research. And over the last few years, I've done teaching for healthcare professionals as well as community groups around some of the structural issues that affect BAME people living with HIV. And of course, also really important to note that these structural issues affect ethnic minority people in other healthcare areas as well. So, for example, last year I gave a talk for HIV Prevention England on the issues to do with HIV and ethnic inequalities. And with COVID coming around, it seemed very clear that COVID was going to be no difference to other health conditions, in that it disproportionately affects people of colour. So I've been involved in some research in East London within my trust, looking at admissions to our hospitals of patients with COVID by ethnicity, and that confirmed the PHE data, which is that Black and Asian people are more likely to be impacted by COVID. And I've also written some articles regarding health inequalities and COVID.
Thanks very much. And now to ask our panel to introduce themselves, starting with Shamal Warwick. Shamal?
Hi, I'm Shamal Warwick. I'm a senior peer support worker at Mortimer Market Centre, Bloomsbury Clinic Sexual Health, and I also work as a social prescriber, which is providing non-medical support services to residents and patients, working quite closely with general practice in Waltham Forest.
Hello, I'm Jide, and I work as a project coordinator for Africa Advocacy Foundation and also doing a research project with Sophia Forum. I have over 10 years experience in sexual health, and I'm very passionate about work around BME communities in the UK.
Hello, I'm Adela Senkubuge. I work with George House Trust as a services advisor. George House Trust supports people living with HIV in Greater Manchester.
I'm Jide Macaulay. I'm the founder of an organization called House of Rainbow. Our organization supports Black Africans who are lesbian, gay, bisexual, transgender, and intersex people. And it started 13 years ago. And also recently, I became the first vice chair of One Voice Network. One Voice Network aimed to drive health equality and improve outcomes for Black communities right here in the UK, and particularly those affected by the HIV epidemic.
The burning question that everybody has at the moment is what to do if they themselves get COVID-19. It was your question, Judy. Would you like to talk about that now?
Thank you. And I would like to find out what advice you have for people living with HIV who have contracted or suspect they may have contracted COVID-19 and are self-managing at home before the situation becomes life-threatening. Is there any, and before they call 111, you know, when it's life-threatening. There are guidelines to avoid contracting COVID-19, and there are guidelines on what to do if you're admitted in hospital with COVID-19, but there's nothing specific around self-managing well at home while you're self-isolating. Are you able to throw some light on that, please? Thank you.
I think that's such an important question, so thank you for that. And I might talk first of all about just giving some advice to people, as you've asked about people who are at home with possible COVID, but also maybe take the opportunity to talk a bit about what we know about the impact of COVID on people living with HIV. So first of all, I'd say if you're at home and you're self-managing, if you live on your own, or if you are, for example, a carer, just the sole carer of someone, or a single parent, if you start to feel unwell, I think it's really important that you tell somebody. So whether you have a friend you can call, or perhaps a family member, just someone who can ring you to check up on you and check that things are okay before things get worse. So I think that's really important, that people, if they can ask someone just to check in on them on a daily basis by phone or by text or whatever that means. So I think if you are feeling unwell with COVID and you're not feeling unwell enough that you need to call 111 or 999, then there are several things that you can do at home. So some of the most common symptoms of COVID are high fever, persistent cough, feeling kind of achy all over, feeling more sleepy than normal, for example, and also losing your taste or smell. So things you can do are quite simple, really. So the main thing to do is to get some rest. So if you can rest, make sure you drink lots of fluids. And when I mean fluids, I mean so lots of water. And if you're not eating or drinking well, then having some water or drinks with some sugar in it or salt in it will help hydrate you. And if you feel like eating, then try and eat quite simple foods that are easy to digest. And if you're having fevers, then taking something as simple as paracetamol regularly is really, really important, because that can bring down the fever and help with the all over body aching. So those are probably the most important things. They're very simple, but they are effective, and sometimes you just have to wait for the symptoms to go. But obviously, if you are worried and you're feeling that you're getting worse, and you're not sure, then that's when you ring 111, or that's when you call your GP or your HIV clinic to get more advice. I realise I haven't talked about how to get a test, and that's probably because it keeps changing. So I think the best thing to do is to probably call 111 or look on the website, the NHS website, and see how to get a test near you. So that's probably what I would recommend. And I guess the other thing that's really important is, if you're living with HIV, is to carry on taking your HIV medications. Don't stop unless, of course, you're vomiting or for another reason you can't take them. So that's probably what I'd advise if you're at home and self-managing. And I guess, as I said, this is quite a good opportunity to talk about what we know about the impact on COVID on people living with HIV. So COVID is obviously a very new disease. We didn't know about it till the end of last year, and I think we're still finding out a lot about it. And in terms of research, there is still quite a lot to do. The evidence we have so far comes from what are called case series. So kind of numbers of patients living with HIV who have been admitted to hospital, and there's been lots of case series published around the world. And so far, the evidence from that is that if you are living with HIV and you're on treatment with a good CD4 count and you have an undetectable viral load, then you shouldn't be at increased risk of getting COVID, and you shouldn't be at increased risk of having more severe symptoms than anybody else. So that's what certainly what we've been saying as the British HIV Association, and also other medical organisations as well. But we don't have that much data yet, and it's really important to look at what's new and what's coming. We assume that if people are immunosuppressed, so if they have a low CD4 count or they're not on treatment, then they might be at increased risk of more severe symptoms of COVID. And British HIV Association has recommended that if your CD4 count is less than 50, or you've had an opportunistic infection within the last 6 months, then you would be advised to shield. So that's been the advice so far. And if your CD4 count is less than 200 or you're not on treatment, then perhaps taking more precautions in terms of trying to avoid COVID would be sensible. Because obviously this session is looking at BAME people living with HIV. We know generally that BAME people are more likely to suffer more severe impact of COVID. So I think the risks for BAME people living with HIV are to do with the fact that they are BAME. And I think we're going to talk a bit more about the reasons of why people of colour might be at risk of more severe symptoms later on.
Now, moving on to your question, Shamal, or one of your questions.
Yeah, so we were just discussing the public health England review on COVID, which found that certain ethnic minorities are disproportionately affected by the risks and outcomes of COVID. That didn't come as a surprise, because I think that is very relevant, as you said, Rageshri, for other health issues. However, I read a statistic a couple of days ago which was saying that it takes 4 to 6 visits or engagements for people from ethnic minorities to even be taken seriously in general practice. So how can we encourage ethnic minorities to actively seek and ensure that they are provided with effective and efficient access to health and social care?
So I think there's probably several different things we need to think about. So first of all it's about giving people agency, so educating them so they know how to why they need to access healthcare, when they need to access it. So giving people the agency to really look after their own health. And I think that's something that Public Health England talk a lot about in the BAME COVID review that was released last week. So they talk about how we need to have culturally competent. So that means promotional material and education, which is appropriate for different ethnic groups, whilst not stereotyping them, but making them more appropriate and accessible for some groups, so that they have the education and know when they need to access healthcare. So I think that's one part of it. And I think actually that's something we could improve in all aspects of healthcare, not necessarily just to do with COVID. I think that's something we need to improve on. I think we often don't know how to make ourselves easier to reach. So I like to talk about clinics being hard to reach as opposed to patients. So how can we be more accessible? And I think we need to do more community participatory research. So that's research which are led by the communities, as communities will know best what are the best kind of solutions to problems around healthcare. So more research that values the voices of communities with regards to finding out what works, what interventions work to help people get into healthcare. And then in terms of other things, so in the wider NHS, there are policies that can put people off from accessing healthcare. So for example, in terms of the hostile environment for migrants, so people may be put off coming to healthcare because they might be worried that their data will get shared, that if they're admitted to hospital, they might get deported, or they might have to pay a very large amount of money for their healthcare because they're not, they don't know if they're eligible or not to get free NHS care. So I think all those things in different levels are needed. So the research, the culturally competent education and promotional work, as well as looking at wider policies that impact on people of colour accessing healthcare.
Do you think the use of clearer language could help improve health outcomes for Black African communities here in the UK?
Yeah, I think better communication overall would be helpful for all groups. And as part of the BEVA External Relations Committee with Joe, I think we've been working really hard on trying to make sure the messages that BEVA gives out are clear and understandable. But that's not everything, of course, because not everyone can, for example, speak English. And in this way, I think possibly the government could do more. I'm going to take the opportunity to mention Doctors of the World, which is a charity which, with the support of the Mayor of London, now has on its website information about COVID in 60 different languages. And I think probably about 8 of them were in African languages. And they've also, that information is written, but it's also in audio format. So if someone has difficulty reading, then they can listen to it. And there's also several videos in different languages as well. So I think that's really worth a look on their website. It's also on the Public Health England website.
Yeah, in our community, people are very concerned because when they talk about the high numbers of Africans with COVID-19 in Britain, and they talk of deprivation that many BME communities are facing, and they compare themselves with people who are living in Africa, for instance, where actually people are living in abject poverty. They have no clean water to wash their hands. They have no jail, but they have recorded a very low number of people who have died of HIV, of COVID-19. For instance, in Uganda, they haven't recorded any death at all. So people are not sure, even going to the hospital, that one is like questionable, how other people who are living in Africa in abject poverty can survive, but you are living in the UK, but the chances of surviving are very low. So they are not sure.
I think that's a really good question, and the answer is very complicated, and I think we're still finding out more. So I'm going to make some suggestions. So as you said, yes, Black people in this country are disproportionately affected by COVID, as are some Asian groups, so especially Pakistani and Bangladeshi people. And that's been confirmed by several different studies. And if we need to really think about what's different about Black and Asian people living in the UK, why are they experiencing more severe COVID than people in their own countries? So what is going on there? What's the difference? And I think there's been a lot of work, and it's certainly mentioned in the Public Health England report about issues to do with structural racism and health outcomes. And I might spend some time just discussing that at the moment, if that's okay. So for example, we know that in this country, we think BAME groups are more likely to be exposed to COVID. So therefore more likely to get it, and that's because they may be more likely to be in positions where they might catch it. So for example, working in jobs which are public facing. So for example, working in transport, in catering, in the NHS, for example, they may be less able to do jobs where they can work from home. And we know social distancing is a privilege. To be able to work from home is not something everyone can do. We know with the relationship with deprivation that ethnic minority people in the UK are more likely to live in poverty, more likely to live in high density housing in areas where there's not much green space, where there's more air pollution. All those things together can impact on health. And when we think about it in the UK, why is it that ethnic minority people are more likely to live, in these conditions? Why are they less likely to work in higher paying jobs, etc.? And I think one of the reasons to do that is structural racism. So that's not the kind of racism where someone says, horrible things to one person. So not kind of one-on-one racism, but structural racism in the way that if you look at the most deprived populations in the UK, they are Black and Asian groups. And as I said, much more likely to live in poverty, etc. So I think all those things together can really impact on health. And if we look at other health conditions, so certainly the conditions which we've seen, which have been related to poor COVID outcomes. So for example, diabetes. We know that if you have diabetes, or especially uncontrolled diabetes, there's an increased risk of poor outcomes with COVID. So diabetes is very much a condition which disproportionately affects ethnic and minority people, and that is often related to lifestyle. So, and when I say lifestyle, I'm not talking about choices. I'm talking about being less able to afford perhaps, food that is healthier, because you might, if you're not earning much money, you might not be able to afford fruit and vegetables and healthier foods, for example. We also know that that's one of the ways in which structural racism can affect health outcomes, which can make people more at risk of getting COVID and of having worse outcomes. But there's also increasing evidence, I think, about the actual chronic stress that living with racial discrimination every day can do for people. So we know that living with chronic stress due to racial discrimination can actually cause changes within the body. So for example, it can increase stress hormones, like there's one called cortisol, which means that that can increase blood pressure. It can cause changes to blood sugar, can cause changes to fats in the blood. And it's thought that over time, this chronic stress causes a kind of weathering effect, which can mean that people from ethnic minority backgrounds are more likely to have conditions which may mean that they have less good quality of life, less life expectancy. So more diabetes, more high blood pressure, more kidney problems. All those things can really impact on health. So I think when we look at the differences between ethnic minority groups living in the UK, and this is replicated in the US as well, they face a very different life experience to people in their home communities. And what is the difference? The difference is exposure to racial discrimination. So I think that's something that needs to be looked at. And it's probably something that we don't talk that much about in this country, whereas actually in the US, clinicians and academics talk about this a lot. And I think that's something we need to do more here, to see how aspects of structural racism can really impact on the lived experiences of Black and ethnic minority groups here. So yeah, I think that's probably going to be the most likely thing. And it is mentioned in the PHE BAME COVID report, they have mentioned structural racism, which I think is a really important step forward.
Some people have told me that they wouldn't go to the hospital now because they are scared. They think it has nothing to do with their color, but it's to do with other things they don't understand, because they are saying, if you talk of poverty, actually people in Africa really are living in poverty. So there's something else that is killing them, not actually poverty or deprivation or other underlying issues, because also in Africa, people have diabetes, which is not even treated. They have all sorts of underlying issues, but the number of people who are dying there is not as high as what we are experiencing here in the UK and other countries like the US. So many people are thinking they're not going back to the hospital because they think if they go there, they're not coming back.
So just to say, in terms of access to healthcare, I think the studies have shown that people from ethnic minority groups are just as likely to receive intensive care and critical care. So that's, it's not an issue to do with being denied access to kind of the more intensive medications. But you're right, there, as I said, there is something different. And I think we see, I think it's been especially talked about with the NHS workers who have died of COVID. So the fact that, you know, the majority of NHS workers, including some highly paid doctors, have died, and they've been predominantly Black or Asian. Work done by the British Medical Association as well as the Nursing Association has found that BME people are more likely to be on the front line, so more likely to be redeployed to work directly with people with COVID. And because of a culture of kind of discrimination and bullying, they feel less able to speak up. So when there's not enough PPE, less able to speak up and complain about it in comparison to their white colleagues. So I think, you know, it's not just deprivation. I totally agree. And I think the theory about weathering and chronic stress, I think, is really important. And I think that's something that needs to be looked into. And certainly there is evidence in the UK that chronic stress due to racism can cause biological changes that can cause this weathering and increase risk of poor health outcomes.
Some studies have shown that people with vitamin D deficiency are more vulnerable to a range of respiratory diseases, including COVID-19. What is being done to ensure that these groups of people who are highly affected by COVID-19 and also lack vitamin D are getting sufficient vitamin D?
So I think the evidence for vitamin D in terms of preventing COVID is conflicting at the moment. So there is evidence saying it may be helpful and evidence saying it may not be helpful. And the reason it's important is that we get most of our vitamin D from sunlight. And we know that people with darker skin tones are more likely to be low on vitamin D, especially during the winter months. And Public Health England made a recommendation at the beginning of lockdown for everybody to take a small vitamin D supplement every day because of lockdown, because people were getting less exposure to sunlight. As I said, there's been lots of research being done on this at the moment to see whether vitamin D, taking a supplement every day, may be beneficial, especially for BAME groups. And as I said, the results, some say it's helpful, some say it may not be helpful. I think it's not going to do people harm. So taking a vitamin D supplement may be advisable, but I don't think being low on vitamin D is the reason for such different disparities in terms of outcomes. I don't think it is the sole reason, but I certainly think taking a supplement won't do any harm.
What are the improvements that the NHS is doing in order to help Black communities? And of course, my second question is, men who have sex with men living with HIV in my community have been concerned about sexual relationships. What should people look out for during COVID or post-COVID-19? What are the risks? And how can we help many improve their sexual health, mental health, and well-being?
Okay, lots of questions. So your first question was about what are we doing to improve care?
Absolutely.
So I think this is such a good time to get involved with how to change care. So I know UK CAB are doing a survey at the moment on the experiences of people living with HIV, because certainly HIV services have gone through rapid change over the last 3 months. So services have had to stop walk-in Many have had to stop routine appointments, and much of, lots of staff have been redeployed to the wards, and certainly that's something that I experienced as well. But services are reopening. We're doing much more virtual clinics, so telephone, video, etc. And I think we're really trying to work out what we can do, how this is going to work. So certainly for some people, the telephone clinic may be fine, but for lots of people, they may not be able to speak on the phone at home because of privacy issues. They may not have told anyone in the household about their status, lots of reasons like that. So I think it's important to say that both types of services are available, and even if your clinic is saying have a telephone appointment, you may still be able to organise a face-to-face appointment. So that's what we're doing. We do have booked appointments for some people who need to come in, and by having lots of telephone clinics, it creates capacity for us to really concentrate on the people that need it with more needs, and people who may not just need medicine, they may need help with other things, like, for example, letters around benefits, etc., immigration status. We can spend more time on those people. But I think now is the time to have your say. Clinics are changing, and we want to be able to change in a way that is effective for everybody and not just some people. Moving on to talk about sexual health and mental health. So as a sexual health doctor, it's been a very strange time because we've been telling people since the beginning of the pandemic to avoid having sex, and we don't normally talk about abstinence at all. We talk about safe sex and consensual sex. So there is a risk of transferring COVID. It's not a sexually transmitted infection, but you can transfer it through saliva and other bodily fluids, so kissing, for example, and also oral sex. And there is evidence that it can be found in other bodily fluids, for example, in poo and semen. So I think real care needs to be taken, and we would still advise, obviously, if you have symptoms of COVID, you should avoid having sex with anybody. And if you live with someone who you have sex with, then that will be fine as long as neither of you have symptoms. Otherwise, reducing number of partners to be safer is sensible. And if you are having sex with a new partner, then being very careful. So in terms of, for example, making sure that you shower beforehand and afterwards, trying to reduce transfer of fluids. So even through kissing, certainly things like mutual masturbation can be, an alternative. If you are having penetrative sex, to use condoms, to think about dental dams, and to try and avoid having oral sex where COVID can be transmitted. And of course, the other thing is that you may have sex with someone who you're not in the same place with. So, for example, having sex with someone online would be a very safe way to do it as well. And then finally, you were talking about mental health. I think that's such an important thing. I think the impact of COVID on mental health for everybody is huge. And I think we don't know how long lasting that impact will be. And because it's a really uncertain time at the moment, I think we can all feel like we're not in control of our lives, and that can be very, very stressful. So some of the things I talk to my patients about is trying to keep routines. So having your daily rituals, trying to exercise, trying to eat regularly, healthily, minimize alcohol, try to sleep at regular times. And the other thing is, of course, that being socially distanced doesn't mean that you can't talk to people. So, try and talk to your friends and your family. Don't be isolated from that point of view. And mental health services are still available, so they are accessible, although they may be by telephone. So really important to think about that as well.
Currently, because there is lots of research going on, what research do you know that is being conducted and proposed to assess the effects of living with HIV in different ethnic minorities? And how does that research differ by race, ethnicity, or cultural background that you know of that's happening at the moment?
So, I mean, obviously I don't know about all research that's planned or going on, and certainly there has been an emphasis on that. I can tell you that there is, at BEVA this year, there will be presented a study looking at HIV outcomes in the UK Chic cohort, which is the largest UK cohort of people living with HIV, and that's going to look at HIV outcomes by ethnicity amongst heterosexual men and women. So I know that is coming soon, and there has been increasing kind of research on ethnicity. So last year there was data presented from the prime cohort, which showed that older women living with HIV, there were high levels of psychological distress for everybody. But for Black women, they were less likely to be diagnosed with depression or receiving care, so less access to care. So I think we're starting to see more data which looks at ethnicity in particular.
Something I will refer to as COVID stigma, when it's both experienced by fear to seek help because they don't have confidence that they'll be dealt with appropriately in the hospital, as well as associated with carrying the COVID virus, because the news is talking about BAME people mostly dying or having COVID-19 or carrying the virus along. It doesn't help that majority of them are in the key worker roles. And therefore, there is a fear to come out and seek help, fear to say they've had COVID in the community. And therefore, I don't know if you can tell us a little bit of what is being done to address COVID-related stigma in the Black African community. Thank you.
I think that might be something that I would like to ask you as well, to be honest. I think what you've described there is terrible, that people can't access medical care that they need and that they're not being believed, that they're almost being found to not being credible people to, you know, in terms of people believing their symptoms. So I'm really sorry to hear that. And I have heard of cases as well where people have phoned for ambulances and they've not been sent when people have been unwell. And I think that relates to bias. So we know there is something called unconscious bias, where which we all have some kind of unconscious bias, whether it's to do with ethnicity, gender, sexuality, other issues. And that's really, bias is when kind of our pre-existing beliefs and societal beliefs impact on us, and we may not even be aware that we are using these beliefs when we make decisions. So it's really common in healthcare. We know it happens a lot in health. So for example, if I give the example of women, we know that it's very common for women's pain not to be believed. And when we look at one of the most common gynecological conditions, endometriosis, we know it can take up to 7 years for women to get a diagnosis because people don't believe that they're in pain and that they're worthy of having investigation. So, and this is more in Black women than white women. So unconscious bias is a huge thing and is starting to be addressed more in healthcare. People are starting to have unconscious bias training, but again, the jury is really out on whether that works or not. And in fact, I've just done some training for some A&E doctors around structural racism, but also unconscious bias as well. So I think it is a real issue, and that's why people aren't getting access to healthcare. I think stigma is huge. I mean, obviously, HIV stigma is a big thing. So for BME people living with HIV, having COVID on top of that and overlapping stigma must be really difficult. I think what's really key is information. So trying to challenge misinformation. And, you know, I have a very large Indian family all across the globe, and some of the messages being put about COVID in our family WhatsApp are not correct. And I think we all have a duty to challenge misinformation and try and get our information from valid sources. And the other thing is, you know, communities don't trust healthcare professionals, they don't trust institutions, and there's lots of valid reasons for doing that, for that mistrust. You know, there's a huge history of medical exploitation and unethical research done, especially on Black communities and other ethnic minority communities. So it's, you know, it's not surprising that people don't trust us. So I think in terms of COVID stigma, I'm not sure it's even being talked about much amongst healthcare professionals. So I was wondering, Judy, if there's anything that you've heard of to tackle COVID stigma in Black African communities or elsewhere.
I can actually respond very quickly to that. Thank you so much. I mean, this is certainly one of the emerging trend at One Voice Network. We want to make sure that the information that is being passed down, particularly to the Black African community around COVID or HIV, is actually culturally sensitive. It can provide the assurance that they need. And you're very right about the numerous, you know, theories about COVID-19 and so on. And I think, again, when we have a government in the UK that is quite, you know, misleading in a way. I mean, recently, you know, Matt Hancock, made this information that there is now testing and that's available, and that, you know, Black people will be on the front line. They will come forward quickly. And I think that raised a lot of suspicion within the communities about, whoa, hold on, all of a sudden we're now a priority, for this. No, and that obviously is an alarm bell for many. And I think that the other thing again is that people still feel being exploited as well. That, I think that our government and our health service can address some of the other inequalities that has put Black people in this place in the first place. Why are we not prioritizing housing? Why are we not prioritizing jobs? And, when you spoke earlier on, Dr. Rageshri, you talked about the wealth inequality that has also been part of the process of the poverty that we see. So, people are living in council houses, over-age children are still at home with their families because they can't afford to move out. This is part of the problem, and we will definitely continue to see that within the Black, Asian, and minority communities. So for One Voice Network, we certainly will be prioritizing the information. We'll be looking for the best partnership with many service providers in order to move that forward.
Dr. Rageshri, you mentioned that people living with HIV and on effective antiviral treatment are currently not at an increased risk of getting coronavirus or developing more severe symptoms. Is there evidence that being on HIV medication may actually prevent you from getting COVID-19? Because many people in my community understood this message to mean that HIV treatment kind of gives people protection from being infected with coronavirus.
So quite early on in the pandemic, there were trials being done to look desperately for any drugs that might help treat coronavirus, and they looked at HIV drugs, so including Kaletra, Truvada, and Darunavir. And so far, the evidence from those drug trials show that these HIV drugs are not protective against COVID, and they don't treat COVID. In terms of people living with HIV, taking antiretrovirals every day are protective in the way that because they keep your immune system healthy. So it's more about keeping your immune system healthy and suppressing the HIV. That helps in terms of making sure your symptoms aren't more severe. But there's unfortunately no evidence that it's specifically HIV drugs that work against COVID in any particular way.
Many of our organizations are grassroots. So again, this is something that, like we said earlier on, the Mayor of London, for example, have a website that has many things translated in 60 or more languages, and even including audio transcription. Within the Black community, we don't have access to that kind of funding or resources to do that. Then how do we share? And I know that there are organizations that have also created, cartoon messages as well to put some pictures around the COVID messages. We don't have that resources. Once I believe we have the capacity to do so, we also need the funding so that we can carry out these exercises routinely and vigorously and radically, so that the wrong information will not be going out. I think Adela made a great point. The idea that people who live with HIV cannot catch COVID-19 was definitely one of the top 10, myth in the very early stages, and it was dangerous, to be quite honest. So even I thought it was the case, but thank God that I didn't share that message with my community, because I was waiting for a realistic information. I definitely go to the British HIV Association's website to look for updates. I particularly look for Dr. Rageshri's writing as well, because, these are reliable sources. I'm serious. Actually, I have to say this, you're my favorite doctor, and I love you so much. I've been wanting to say that, I think it goes to, when you included House of Rainbow in your presentation, I go, okay, that's it.
You're so easily pleased.
So I think that honestly, we're doing great, but as a community, we also need to push our government to say, look, work with this grassroots organization, work with these individuals. It's very easy to put any of us on this panel, onto a radio show, a television program, to say, let's get them to speak the messages that will go out to their communities. And that is one of the effective ways. These things actually cost money as well.
So the PHE BAME COVID report, one of the recommendations was that funding must follow their recommendations. That's what they're saying. Whether that's true in reality or not, difficult to know at this stage, but I guess they're saying they want to fund community organisations, so keep an eye out for what is coming.
It's also one of the key recommendations that's been made to the all-party parliamentary group, who are asking for submissions about the impact of COVID-19 on HIV communities. And it's one of the things that's been said strongly, I know, by BIVA, also by UCAB, and by the Sophia Forum, all of which I've seen the submissions of. But we have to all push together. And
just following on from what you said, Joe, and what Jide said, I think these platforms are brilliant, and it should be led by people from these backgrounds to be able to have the opportunity to challenge those organisations that are doing the research, that are getting the funding, to be able to say that, look, we are people who work within the community, we understand them, and we are the best people to be placed to be able to advise and provide you with the recommendations. So I'd hope that these platforms and these voices that we're doing in these little sessions, we can then use these to amplify our voices. So the resources and the funding will come, but we should be there to challenge that.